All right, committee will go ahead and bring. We won't. Does that work? Okay, test. Here we go. All right. Welcome, committee. We'll go ahead and bring the Welfare Reform Committee to order Thursday, March 16th. Got a few things on the agenda regarding minutes. We'll bring all the minutes to next Thursday's meeting. I think there's a couple of things where Gary's finalizing on those, so we don't have any minutes today. So the items on the agenda today, House Bill 2179 and also a briefing on Medicaid. We'll go ahead and start with a discussion on House Bill 2179, and I'll ask Jesse from the Revisor's Office to do a quick overview of that bill.
Thank you, Mr. Chairman. Good afternoon, committee. House Bill 2179, it deals with KSA 39709, and it only relates to child care subsidy. So current law requires that to be eligible for a child care subsidy, you have to cooperate with child support services. And also that when you are eligible for those child support or that child care subsidy, you have to assign away, you have to assign it to the secretary so that they can receive those payments. And so what this bill does is it proposes to strike that requirement altogether so that in order to receive a child care subsidy, one would no longer be required to cooperate with child support services.
Thank you. Any questions for Revisor's Office? Representative Lewis?
I'm not looking at the bill now, or the amendment, but I didn't think it said you didn't need to cooperate. It just didn't define cooperation as not being in compliance with all of the provisions. Am I missing that? You still have to be cooperative.
Thank you, Mr. Chair. Yeah, Representative, so it not cooperating with child support services disqualifies you from receiving the benefit. And so what that subsection B10 does is it lists the child care subsidy and the penalties for not cooperating. So therefore, disqualifies you and renders you ineligible to receive it.
My understanding is D9 says individuals who have not cooperated with TANF work programs shall be ineligible to participate in food assistance programs. And 10, before the amendment we're voting on, tried to define non-cooperation as failure of the applicant or recipient to comply with all the requirements provided in state and federal law, state regulations, and so forth. So am I not to understand that that's just taking the definition of non-cooperation out, but it remains a requirement of cooperation?
Take it. So I had to read this 5 times and still struggled with some of the terminologies, the triple negatives and everything else included in the language. I made that triple negative up. I don't know if there are any, but it is rather confusing. So I think what the bill does is it strikes the ineligibility for the child care subsidy from the two benefits that would become ineligible if a person does not cooperate. So as I read this, this says the period of ineligibility, so the bill as introduced, the period of ineligibility for TANF benefits based on the parent's non-cooperation are as follows. But there are no longer periods of ineligibility for the child care subsidy. So it's removing the punishment, the period of ineligibility. This bill would remove that period of ineligibility for non-cooperation. For the child care subsidy. Is that, are you seeing something similar?
Yeah, okay. I'm still confused. I take what you're saying is true, but I couldn't follow it.
Yeah, so I believe the intention of the bill, so currently there is a, I'll just say a punishment, right, for non-cooperating, not cooperating with child support services. And if an individual doesn't cooperate, there are punishments, if you will, and that's the A, B, and C, D. And those are the penalties.
Right.
So what the bill language as introduced does is it simply removes the child care benefit from the benefits that somebody has to comply with.
Okay.
So now, as far as child care subsidies, it's not even really related to the child support cooperation.
I think
That's where the triple negative comes in. Representative Meyer?
Thank you, Mr. Chair. I'll also make an attempt to clarify. So unlike 2141, which was passed out, this one simply removes the need to cooperate with child support enforcement for the non-custodial parent to receive child care assistance. So that would allow them, though, even though they aren't they're in the non-cooperative part of it, but as we discussed previously, there are certain things that fall under that. That would allow them to still apply for child care assistance for the child that they have in the home, not the one that they have custody of. And it just still, it keeps the other penalties in place for the other ones as in 2141. Yes.
No, I think this is important and helpful because, like I said, it's so I'll jump a little bit ahead. One of the ideas for next year is to consider a full rewrite of this statute. And I think some of the conversation, including this one throughout this year, has shown that it can get kind of rewritten a little bit so things are easier to understand. So that'll be a little project we might take on next year. But it's definitely needed. So. Any further questions, committee, on the bill from the revisor's office? We open up for discussion then on the bill, and I'll go ahead and start the discussion with offering an amendment. And once it's passed out, I'll briefly explain it.
attempt
All right. Thank you, Mr. Chair. Jesse with the Revisor of Statutes Office. I'm going to take a moment to explain the amendment that is before you. So the amendment, what it does is on page 5, after that, under B10, after the stricken language of non-cooperation is through policy, it designates that as paragraph A. And so therefore paragraph A would be the period of ineligibility for TANF benefits based on parents' non-cooperation, and then the penalties, and re-numbers those according to the way the numbering and formatting is supposed to go. And then it proposes a paragraph B. So the period of ineligibility for child care subsidy based on parents' non-cooperation, and then it assigns the same penalties as above. So for the first penalty of not cooperating with child support services, 3 months, you would no longer, you would be ineligible. Or the first penalty is 3 months and then cooperation with child support services prior to regaining eligibility. Second penalty, third penalty, fourth penalty. And that paragraph B is even divided into two. You have little I and two little I. So under two little I, and this applies to just the child care subsidy in relation to cooperation with child support services, is that it directs the secretary to review child support compliance of a parent at certain times. And those times are upon application for the child care subsidy, after 12 months of continuous eligibility for child care subsidy, and following such 12 months of continuous eligibility when the secretary renews or determines a parent's eligibility for the child care subsidy. And then since this amendment is putting back in the penalty for non-cooperation and is thus requiring the cooperation with child support services, on page 18, it is reinserting that the requirement to assign the rights for those payments to the secretary when you're receiving child care subsidy. And so you can see the language that was struck in line 30 and line 39 were child care benefits, and now it says child care subsidy. And the difference between child care benefits and child care subsidy is just the same word being repeated as above, rather than having two different phrases and creating a confusion that way.
Thank you, Jesse, and I'll just further explain real briefly. So my intention with the amendment is to do 5 things. One, it fixes the concern with the federal compliance letter with regards to the federal complaint that we stopped benefits before 12 months of those benefits were paid out. So this just allows the compliance for cooperation to happen upon application and then after 12 months. So they get automatically, once they're getting the benefits, they get the benefits for 12 months, and those benefits can't be stopped. The second reason is it somewhat continues existing practices for the most part, just allows that child support cooperation to be part of the application. And the third reason, it works with the annual redetermination for benefits, I think currently is practiced. Fourth reason is it eliminates the $500,000 fiscal note, which, yeah, the feds pay it, but ultimately somebody's paying for it, I think. And then the fifth reason is that it helps continue the encouragement of child support payments. I believe that's the intention of why it's in there now, and I think it's a good thing to continue to encourage those child support payments to be made. Happy to stand for questions. Any questions for revisers, or I'm happy to answer as well. Representative Roth.
Just maybe a technical question. In other areas of this document, it talks about the secretary or designee, and then under the B2I, it just says the secretary shall review. And so should it say there that the secretary or designee shall review child support?
it could, but I know throughout statute, we had one issue in, I think, the past few years where that came up, but I think it's kind of implied, but I think it's somewhat implied
I
with the
understand
secretary.
that we might understand it's implied, but someone else reading it, not privy to us, would see it as a detail. I just saw it, and it's okay, but because it says the secretary shall review. Yeah, it says that in other things throughout the bill, or other areas of the bill, and it's just, sorry.
That's all right. That's all right. Representative, did you have a question? All right. So good. Representative Meyer?
Thank you, Mr. Chair. I would like to ask, how does the DCF feel about this amendment? Is this something that, because I realize that this bill was brought to us in order to make sure that we had a fix. Is it okay if I request the DCF provide us with their thoughts on this amendment?
Sure. If Madam Deputy Secretary Tanya Hayes.
Thank you, Mr. Chair and committee and Representative. Yes, we appreciate the information that will assure compliance with the federal regulations, and we believe this language will satisfy that federal regulation for compliance for Kansas, and we appreciate the opportunity to have this language.
Would you be okay with a few more questions during the discussion? Okay, I think Representative Meyer.
Thank you, Mr. Chair. So as I was going through this amendment, I just wanted a little bit of clarification on what it is that, so if an individual was to apply and be found by the DCF to not be cooperative with child support at the initial application, would they simply be denied, or would they be offered avenues to receiving the child care subsidy so that they could receive that assistance in order to go to work and continue to try to make those payments? Or how would that work with the initial application?
Thank you, Mr. Chair and Representative. It's a little bit difficult to answer. There could be complicating factors, and I don't know if you recall, we went through some of our definitions of good cause. So certainly, depending on the application, the nature of maybe an inability to get information and able to pursue that child support, there would also be then opportunity for good cause, a greater understanding, a conversation with that individual. So all of those processes and procedures to get at the root of when our agency feels like we don't have enough information or haven't been able to navigate to the right information for child support, all that would still be in play in our policy. So it would depend on a number of factors.
Okay, thank you for that answer. My next question would have been also regarding what would occur after they got to their 12-month review period. From my understanding through reading this, it looks like they would be then subject to the different first, second, third, and fourth penalties. Is that correct in your reading of this?
Mr. Chair and Representative, yes, the reading would be correct if that penalty period is applicable and found to be relevant. Again, some of the procedures that we've talked about around conversations around good cause, other efforts to make sure that whatever information the agency feels like we don't have or haven't had on a continuing basis is addressed. So again, the good cause conversations and other activities and those notices would still be in play before ultimately arriving at a decision that a penalty might be applicable.
Okay, I think that's enough for now. Thank you.
All right, thank you. Thanks for taking the questions and your help on this one. All right, thank you. I think we had Representative Wagner.
Yes, to the carry the amendment. What is the reason? I mean, child care benefits is struck out, but child care subsidy is brought in. How is that? How does that change anything?
So the word benefit and subsidy, actually, there was a conversation, I think, with the revisor's office in DCF to clarify that word. And I believe, I'm kind of doing Jesse's job here, but I think subsidy, the word subsidy is used elsewhere in the statute instead of benefit. And so for consistency's sake, that was the question is, can we just put subsidy back instead of benefits in order to have all the language match throughout the statute?
Then, if I can ask a further question, of course, on the page 5 of the bill, where it looks like child care subsidy is struck out there, and I'm just thinking, but you're able to keep it in elsewhere. Why is child care subsidy struck from that page 5? Or am I reading it? Oh, no. Okay. Well, at the top, it's struck out under 10, but then you have a B section. Am I just not following that right? It just seemed like on line 17 and 18, the period of ineligibility for child care subsidy is struck. It just says TANF benefits, but then we go back down and it's kind of brought back into the picture. So there's two, okay, so there's two different, one is for TANF and one is for the child care. Okay, so you have to differentiate. Okay, I'm tracking now. Okay.
The main reason for the differentiation is because of the portion about the secretary reviewing for child support benefits or child support compliance. Sorry.
Got it.
Representative Hoagland.
So that last sentence, you said the secretary shall review, that's where you get rid of the 500 grand? You were talking about the...
Yeah. So as I remember, the fiscal note for $500,000 was due to the change of policy to not check for cooperation. The current system is programmed to check for cooperation, so that's part of their process. And from what I remember, that to remove that check as part of the process, the fiscal note was $500,000 to get in there and take that out of the program. And what the amendment does is it simply allows us to continue with our current practice of checking for cooperation. So there are no changes. The only change is that if somebody is no longer cooperating, they are able to continue receiving benefits for a complete 12 months before those benefits are stopped. So we continue with our current practice, and that's where there's no change to the program, which no need for the fiscal note.
And that will disable the trigger that was 500 to shut off. The trigger will still be there.
Yes, because with this amendment, we are not changing any of the current practice as far as checking for cooperation. We're just changing when. So we're doing it on a every 12-month basis, which is part of the redetermination. But that check would remain in the program. Representative Meyer.
Thank you, Mr. Chair. I knew I'd come up with another question after I read it a little more thoroughly. Would the Deputy Secretary mind standing for another question? Is that okay? Thank you so much. Okay, when reading through this again, I had another question. So upon initial application, how long does the individual have to wait before it is determined that they are cooperating with child support? before they receive the child care subsidy.
Thank you. I'm thinking through the different applications we have in their timelines. We have 30 days to do that initial process, but I believe within 10 days, some of that information is generated to go out and inquire so that they can complete information for the child support services. Does that answer your question?
Nearly. I think maybe a scenario would help. So let's say an individual applies for child care assistance. They have a child in the home. They're trying to get assistance so that they can go back to work or work and fully, pay child support. In that case, how long would they be waiting for the determination to see if they are eligible for the child care subsidy in order to receive those benefits? Because in my interpretation, if it was a long wait, it could impact their ability to go to work in order to pay child support, if that makes any sense.
Our goal is to begin the processing of those applications within 10 days. Within the federal requirements, that parameter is within 30 days.
So during that 30-day time period, so basically, is there an increase in the length of time it would take to process these applications due to the extra step of trying to compare it upon initial application with the child support enforcement agency? Is there any increase in time?
No, there's the current practice around the child support cooperation and the application and information needed for that business operation. So this would not change that. So no, there would be no increase. There's currently processes in place integrated into that initial application. So that's current practice.
Okay, so then just to clarify, so then when an individual makes the initial application, child support cooperation is checked at that time regardless. And then in that case, for any benefits, I guess I should say. So in that case, then it would not cause them a longer wait in order to receive that assistance, you don't believe?
Correct. It would not cause any longer wait in the application process.
Okay, thank you very much.
Further discussion, committee? All right, thank you. Thanks again. See no further discussion. I'm going to go ahead and move my amendment with the addition of or the designee of the secretary. They're under II in the balloon part. Thank you, Representative Roth. That was a good catch. So with that small change, I'll move my amendment and ask for a second. I have a second from Representative Roth. Any discussion on the amendment? Seeing no discussion on the amendment, I'll close. All those in favor of the amendment say aye. All opposed, no. The amendment passes. We're back on the discussion on the bill. Any further discussion on House Bill 2179? See no further discussion. Is there a motion on House Bill 2179? Representative Wagner.
I make a motion, we move House Bill 2179 as amended.
We have a motion to pass out House Bill 2179 as amended. Do we have a second? Second by Representative Howell. Any discussion on the bill? Representative Carr.
Thank you, Mr. Chair. Just a statement. Sometimes in this body, I think we forget that the protection that we should be most concerned with is that of the children. And oftentimes that's not just the child, but the children. I won't be voting in favor of this. I can't vote in favor of anything that will, in fact, in the end, hurt the child. And maybe I'm mistaken in my thinking, but if a parent, any parent, is unable to provide child care for a child, then who then is suffering? Is it the parent or is it the child? Or am I mistaken in my thinking here? I'm trying to find reasons to work this out internally. Is I'm reaching out for help. This is a string I'm throwing. I don't understand how it appears that in this particular body, most of what we've done since I've been here, and again, I'm just a freshman, but my compassion is always for the children, and it would appear that in many instances, we have compassion for a child, but we don't have compassion for the children. There's always another child. If someone is if they're looking for benefits for child care, then that of course would indicate that there's a child that may suffer if they don't have benefits. I'll just leave it at that, and if someone can reach out to my lifeline and give me some clarification, I would appreciate it. Thank you, Mr. Chair.
Representative Pickert.
Thank you, Mr. Chair. Are you ready to catch it? Okay. Well, okay, so when they're applying initially or at their annual recertification, not recertification, but whatever it is. Okay. There's always that, they're always looking for a good cause. So, you know, if the non-custodial parent has lost their job, got sick, car quit working, whatever, there's the good cause. So they could continue to get the child support subsidy, okay? So if they're just a deadbeat and not willing to work, period, and cooperate, that's where it's cut off. So their children could suffer, but that's not the goal. So, you know, if they miss some child support and they have good cause, then they're covered. Is that, I shouldn't have said that one clause, should I?
Representative Carr, but I think if I can jump in real quick, I think the main purpose of checking for child support cooperation is to allow DCF to help that single parent to get that support. And maybe that single parent is not able to track them down, go through the process, but when that single parent applies for child care assistance, their cooperation with child support services allows DCF to work with them to get that support that they need. Representative Carr?
But we're also making the assumption that we're not talking about two single parents, because I know of those situations where someone has multiple children. He has custody of a child, and however there is another child that's in play. So again, and I appreciate your statement because your statement was factual, and you spoke from the position from which you stand. And I'll stand on what I said once again. We have compassion for a child, but it appears as though we have a lack of compassion for the children. There's always another child involved that we should consider with everything that comes before this body. And that's the end of my statement. I yield.
Representative Meyer?
Thank you, Mr. Chair, and I totally understand what you're saying here. I am not the biggest fan of this amendment at all. I think, though, from my perspective, I will be supporting this because I know that the DCF has done their due diligence and trying to bring a good bill forward in this committee to try to eliminate some barriers that folks have come across before and that they could potentially face if the other bill that we passed out of committee, 2141, comes to fruition and is in statute. But no, I think you're right in the way that you're feeling, especially because I think from folks like us who come from a background where we've been through these experiences, either professionally or personally or both, have run into some issues with, say, and not to disparage, please, but with the caseworkers who are operating the programs and how they determine that good cause. And it has eroded some trust that many of our clients and ourselves have had in the system as we push through it. So there is a good reason to fear that this could hurt more children, absolutely. But I understand that, and I'm reluctantly supporting this as amended. I preferred the original bill, but I do think that we need to make sure that we protect these children and these families as best as we can within our power, and considering that we do not have a majority, I think that this is our best path forward at this point, although I do respect you and your thoughts on this and your decision not to support it. I support you in that. I want to be on record about that, but I also do want to say that we do still have concerns about this. I was very excited that the DCF brought a bill forward for us. That I was like, this is a great bill. We really need this, you know, and unfortunately, we don't get everything that we want. But in the spirit of compromise, I will be supporting this bill, and that's all I've got to say about that. Thank you.
Representative Humphries.
Thank you, Mr. Chair. So I'm kind of reaching out for a lifeline too here, because there's this one thing I don't understand. So maybe, you know, we can help each other. In this case, you know, you said we care about the child, but not the children. And so I'm wondering, what I'm having the struggle with is there's a child that's not living with the parent that we're asking them to cooperate with their child support. So that child, it seems like it's kind of one or the other is what it seems like you're saying. Like this child, either we don't cooperate, and so this child doesn't get the child child support that they're due, or this one, you know, if they're not cooperating and paying that, so that child's struggling, then this child wouldn't struggle because they would get their child support. So I'm kind of struggling with, are we prioritizing one child over the other? And that's kind of my question.
Representative Carr.
That's exactly my point. That's what it appears to be from my perspective. The difference is I'm looking from the right side of the wall and you're looking from the left, or however you want to look at that, because and I'm speaking in general with respect to this body, and not so much just directed at this particular bill, but everyone that has come up here. That's every bill that we've passed. That's what it's been. It's been a separation of you know, there's a responsibility for the parent to take care of this child. However, we just disregard the responsibility of the parent to take care of the other child. So my statement was, you know, more to this body in general. But what you just stated was absolutely correct. That's exactly the way I feel. We're just looking at it from the other opposite ends of a kaleidoscope.
Okay, so if I may, Mr. Chairman, if the cooperation is there, then they both win. Both children win.
You're making the assumption that based on the rules that this body has provided with respect to cooperation, that person is in absolute control of the application and abiding by those rules. I, for one, have lived an exceptionally full life, and I understand that there are times when there are things that are absolutely out of your control. And from what I get the majority of the time from this body is that we don't ever take that into consideration, or the consideration there is exceptionally minimal. And again, that's just my opinion, and I won't take any more of the body's time. I just wanted to be certain and make my comments as part of the record, and I yield back to the chair.
Well, I just would say I've been encouraged through this committee of finding out the links that DCF does go to make sure that both sides and both children are taken care of. And I've been impressed by that, and I appreciate what they've done and their explanation of good cause.
Representative Howell?
Thank you, Chair. I just wanted to state that as I look at this bill, as it currently stands, and I look at, to use the analogy that we've been using in this discussion, looking at children at both sides of the wall, so to speak, I feel absolutely confident that both children, all the children, have the best opportunity to receive the maximum amount of help possible, because all the children have two biological parents. And if both parents in this case, in this equation that we're considering, are single parents, they still have non-custodial parents, and they have custodial parents. And if either one of these parents on either side of this wall of these children need help, they have all these resources at their fingertips to maximize the amount of dollars for this child, whether it's through, they have the opportunity for SNAP, they have the opportunity for TANF, they have the opportunity for child subsidy for their parents equally if they have the need. And so I feel this is providing for all the children and not just a child in a certain set of circumstances. And I am very confident, after learning all of the, and the hours that we have spent in discussion with DCF and I don't even know how many hundreds of questions we have asked them. They deserve an award just for answering our questions. That they really do have the best intentions for each individual client and to help them the very best they can. And we are just trying to have a good check and balance system here to make sure we motivate for the best, but also help as much as needed. And I feel like we're doing a pretty good job. So, thank you.
Good discussion. There's no further discussion. Representative Wagner, you may close.
Yes, thank you, Mr. Chairman. I move that we pass, again, House Bill 2179 as amended, favorably for passage.
There's a motion, and it was already seconded. All in favor of the passing of House Bill 2179, say aye. Aye. All opposed, no. Motion passes. And that concludes that portion of the meeting today. Then we'll go ahead and move on, committee. Thank you for discussion on that. And we've got thanks, Andrea. Thanks, Tanya. So moving on, we have a presentation on Medicaid. And so we welcome Sarah Fertig from the Kansas Department of Health and Environment. Welcome, and thanks for coming to committee.
Thank you, Mr. Chairman, and good afternoon, committee. Nice to be here today. I am going to be working off of a slide deck that looks like this. I want to make sure the committee has it.
One quick note for the committee members: this was handed out, I think, on Tuesday, so It could be in your folder. If not, Gary has a couple extra copies, so if you don't have the kind of a lighter blue cover sheet paper, Gary has a couple extra copies.
Mr. Chairman, is everyone situated?
Yeah, we're good to go.
Okay.
Thanks, Sarah.
We use two different styles on our slides to make it easier to distinguish between the two presentations. So hopefully that helps you get to where we are. So my name is Sarah Fertig. I am the Medicaid Director for the state of Kansas. I work for the Kansas Department of Health and Environment. With me today is Christine Osterland. She will be doing the second part of our presentation today on Medicaid continuous eligibility unwinding. I will get us kicked off with an overview of Medicaid. Now, I know this committee has been doing a lot of work to understand the programs that DCF operates, and you're probably learning that a lot of these are pretty complicated with lots of rules. Medicaid is exactly the same way. It is incredibly complicated with lots of rules at both the federal and state level. So if you're hoping for a breather from complicated programs, I regret to inform you, you're not going to get that from us. So my overview today, I could talk about Medicaid all day long and barely scratch the surface, but today I wanted to focus on some really kind of high-level issues with Medicaid. Number one, what is it? How is Medicaid administered on the state and federal level? Who do we cover in Kansas? What do we cover? When you have Medicaid, what does that mean? And then lastly, what is CanCare? Because we oftentimes hear these words kind of interchangeably. So on the first slide that I have, a little bit of background on where Medicaid came from. So originally the Medicare and Medicaid legislation was passed back in 1965. So these programs have been around in quite a ways. Title 18 is Medicare. Sometimes you hear these used interchangeably. Medicaid is under Title 19 of the Social Security Act. So sometimes we refer to Medicaid as Title 19. And then Title 21 of the Social Security Act is the Children's Health Insurance Program, or CHIP. So inside our agency, we talk about Title 19 and Title 21 a lot. I'll try and avoid that today to make it less complicated. So then moving on, we thought it would be helpful to start to kind of give an overview of what is the difference between Medicare, Medicaid, and CHIP. If you haven't worked in this space before, it can be incredibly confusing. So we created a slide for each of the three programs for just a very high-level explainer of what each is. So Medicare is a national health insurance program for folks over at 65 and up, and some folks younger than that who have disabilities. And if you've performed any paid work, you've paid into the Medicare program. And there's Part A, Part B, Part C, Part D. Medicare is managed by the federal government. There really is not a state component to that. So our division has very, very little to do with Medicare. We have some programs where we can pay Medicare premiums for low-income folks so that they can gain access to Medicare, and Medicare can pay some of their bills. But beyond that, we have virtually no interaction with Medicare. Now, moving on to the next slide, it's slide 5 on my deck. Medicaid is also a healthcare program, but this is for folks with very low incomes who also meet some other type of eligibility criteria. So just being low income is not enough to qualify you for Medicaid in Kansas. You must be low income and meet some type of age requirement, either be a child or over 65, or you must be low income and have some type of qualifying condition. For instance, being pregnant or having a disability. And then you can also qualify by having low income with disability. And all states participate in the program. Believe it or not, Medicaid is optional under federal law. States don't have to create Medicaid programs, but every state, DC and the 5 territories have all kind of grouped together, and they each have their own Medicaid program. So no one has opted out of Medicaid generally. And then the next slide, we talk about CHIP. This is the Children's Health Insurance Program. And sometimes when we talk about Medicaid, we mean Medicaid and CHIP. Our division administers CHIP as well. And it's a health insurance program that covers kids up through age 19 whose incomes are too high to qualify for Medicaid. So it's a bit of a stopgap measure. So between Medicaid and CHIP, Kansas offers comprehensive health care coverage to kids with household incomes up to 250% of the federal poverty level. And the federal poverty levels are set by the U.S. Census Bureau. They're updated annually, so it's kind of an evolving standard. So we cover, through a combination of Medicaid and CHIP, we cover kids up to, with household incomes up to 250% of the federal poverty level, or FPL, as we say. The benefits are almost identical to Medicaid. There's very, very few changes. It's jointly funded by the states and the federal government, and it's very closely aligned with the Medicaid program, so we tend to treat them similarly. Moving on, a little bit of information about Medicaid as an insurer. We are the third largest provider of health benefits coverage in Kansas. The only entities that are above us in terms of number of lives covered is Medicare and Blue Cross Blue Shield. And as of January 2023, we covered almost 540,000 Kansans. That is between 1/6 and 1/5 of the entire state of Kansas. About 60% of those folks are children. And we are the largest insurer of children in Kansas. We pay for about 40% of births that occur in Kansas. And we pay for most mental health services. That's true on a national level, and that's true in Kansas as well. A lot of private insurers either don't cover mental health services or have strict caps on mental health services. Medicaid provides the best coverage for behavioral health. I would also add that Medicaid is also the payer of last resort, which means that if someone has another form of insurance, that insurance will pay first. And then if there's anything left over, the provider can bill Medicaid. And depending on how much is left over, we may or may not pay the extra. So we are always the payer of last resort. So that's a little overview of what Medicaid is. Mr. Chairman, was there a question?
Representative Humphries.
Super quick question. Medicaid, I know children, so that would be 18 or under. And then I didn't realize Medicaid, there was an age criteria, elder. So what's, if it's, because I thought 65 was Medicare. So could you mind explaining that?
Sure. So generally, you can be low income and 65 and up. There are some Medicaid programs and on-ramps to eligibility, as we call it, that apply to that program. But generally, if you are between the ages of 19 and 64, there's not a Medicaid program for you unless you are disabled or pregnant.
And so why would someone 65 or older need Medicaid instead of Medicare?
Well, we do have some folks that are actually eligible for both programs, Mr. Chairman. Those are known as dual eligibles. But you know, we don't gatekeep that. To be eligible for the Children's Health Insurance Program, or CHIP, you can't have any other insurance. But for everyone else, there's not that barrier. So if you have an individual who's 70 years old, they might have Medicare. If they're eligible for Medicaid, they can apply for that. There are some benefits that Medicaid provides that Medicare does not. For instance, some dental benefits and nursing facility benefits as well. So there are reasons for that. Our coverage is more robust than Medicare.
Thank you.
Thank you, Mr. Chairman. So that was just a little bit of a background, very broad overview of Medicaid generally. And then moving along, I wanted to talk to you a little bit about how the Medicaid program is structured between the state and federal. So it's a state-run program, and it's jointly funded by the state and the federal government. The federal matching money is known as FMAP. You might hear this term a lot. FMAP stands for Federal Medical Assistance Percentage. Typically in Kansas, the FMAP is about 59 or 60%. What that means is that for every dollar we spend on medical coverage for Medicaid, about 60 cents of that is paid for by the federal government. The remaining 40% is paid by state general funds. And Representative Humphreys, there on this slide, we also note that there's some folks who can be covered by both Medicare and Medicaid. So I knew that was in the slide somewhere. So it's jointly funded and jointly administered. So on the next slide, giving a little bit of background on the Medicaid state plan, and this is really the backbone of the Medicaid program in Kansas. The state plan is really a contract between the federal government and the state on how we are going to administer the Medicaid program. The state plan has to be consistent with all of the federal rules and regulations that govern what we do, and it specifies who's going to be eligible, the benefits we're going to provide, how the program is operated. It's incredibly detailed. If I were to print it out, it would be volume and volume and volume of our state plan. It's a very, very lengthy, very technical, very detailed document. And all of the state plan, and anytime we want to amend it to change something, all of that has to be reviewed and approved by a federal agency known as the Centers for Medicare and Medicaid Services, or CMS, and that's a division of the U.S. Department of Health and Human Services. So next slide. How does Medicaid work in Kansas? There's really two main agencies that administer Medicaid in Kansas. The first is the Single State Medicaid Agency, which is KDHE, the agency I work for. So our responsibilities include maintaining the Medicaid state plan. We have to amend it all the time to adapt to changes in federal law, state law, if we add a new service to coverage, that type of thing. So a lot of work maintaining the state plan. We set the eligibility policy, working with CMS to allow people to apply for Medicaid. And I should add that the legislature plays a really key role here too. We saw an example of that in 2022 when the legislature authorized us to extend coverage for postpartum women through 12 months postpartum. Before that, they would get cut off from Medicaid at about 60 days postpartum. And we needed legislative authorization for that funding to do that. So you all play a role in this process as well. We also have to maintain some mandatory contracts. One of them is known as the MMIS, or Medicaid Management Information System. That is an incredibly complex system that pays claims for Medicaid services and processes the data that our managed care organizations send to us. That is really just the DNA of the Medicaid system and the data operations of how it works on the financial side. We also contract with Medicaid managed care organizations. As I'll get into a little bit later, we're largely Medicaid managed care state, and we work with 3 managed care organizations, or MCOs. And then our agency is also ultimately responsible for compliance with federal laws and rules. And if you go on to the next slide, you got a little bit more information about what it is we do at KDHE. We are really the primary contact for the federal CMS agency. So that means we're responsible for making sure we're able to draw down federal matching funds to support the program. We're responsible for program integrity activities. That's really detecting and preventing fraud, waste, and abuse. And then we also are responsible for submitting all the federal reports that CMS requires. Moving on, a little bit about the KDADS, the Kansas Department of Aging and Disability Services. They administer the state's 7 home and community-based services waivers, or HCBS waivers. You might hear this term in other committees that you work with. So HCBS waivers are special programs. They provide base Medicaid coverage and then additional services on top of that to help elderly and disabled folks live safely in their community. So it enables them to live at home instead of having to go into a nursing facility. And get a little bit of information there on the 7 HCBS waivers. We could spend all day talking about the 7 HCBS waivers. I wanted to make sure you were aware of what they were, and that KDADS administers all 7 of those special programs for elderly and disabled Kansans. And then moving along, talking about federal policy. So we have a state component to operating Medicaid, and then we have a federal component to operating Medicaid. And really, federal laws and CMS regulations, CMS directives, all of that is really what we have to comply with at all times. And so that's kind of our poll star. And then on the next page, the state level rules that also apply to Medicaid. So state laws, anything that you all pass, we comply with, regulations. And then down to the single state agency, or KDHE level, We make sure that our state plan is consistent with state law and federal law. And then we also operate the CanCare 1115 demonstration waiver, which is really our Medicaid managed care program. So moving along, the next section we talk about who is eligible for Medicaid and what services Medicaid covers. So generally in Kansas, who is covered by Medicaid? Low income plus an age criteria. So they're either children or they're 65 plus. Low income and disability, low income and pregnant, low income and you're a parent or caretaker of children in the home. We also have a program called Medically Needy. This is for folks who have very high medical costs, but their income exceeds our eligibility limits. We have a program that allows them to spend down their excess money on medical costs. It's kind of like a deductible, and then Medicaid can step in and pay after that. We also cover all the foster care kids in Kansas. So if you're a foster care child in Kansas, you are automatically eligible for Medicaid, and DCF helps us determine who's eligible there. Mr. Chairman?
Thanks, Sarah. Representative Meyer.
Thank you, Mr. Chair. Thank you for being here. I had a hopefully quick question. So for individuals, kind of to bounce off of Representative Humphrey's question about individuals 65 plus, for those that have Medicare already, and then they apply for Medicaid, can you tell me approximately how much how their assets would affect their eligibility for Medicaid in this situation?
Sure. So thank you, Mr. Chairman. This is a good question. I am not the eligibility expert on this. We could probably send some information to you after the committee if you like. We have a document. I printed it out in case I needed it. It is a very detailed document with our income and asset limitations. There's also a very thick manual on how all that is determined. So that's perhaps a more complicated question, Representative, and if we'd be happy to provide some additional information. I'm not the SME on that, I'm afraid.
No, totally understand. I even have a hard time keeping track of it myself, but I would greatly appreciate that information in the future. Thank you.
Sure. So the next slide, it's slide 18 on my deck. I'm not going to read this to you, but just we have a list of some of the services that are covered by Medicaid. Federal law sets a list of mandatory services that all Medicaid programs have to cover. And this slide goes through some of them. So there are things like physician services, rural health clinic services, and the like. And then the slide after that is optional services. Federal law doesn't mandate that state covers these services. Kansas has elected to. So these are things like prescription drugs. Believe it or not, federal law does not require Medicaid to cover prescription drugs. We do. So that gives you an idea of everything that we cover. It's very comprehensive. And then the slide after that, wanted to just really quickly talk a little bit about what Medicaid expansion is. It's a term that you hear a lot, but what does that actually mean? When you hear that term, what are you actually talking about? So we have a couple little slides in here just to explain what that is. What it does is it basically bridges the gap to allow adults who have low income, but not that extra qualifying criteria. They're not low income and pregnant, low income and disabled, low income and elderly. To access Medicaid benefits. So this would be for folks aged 18 to, between age 18 and 65, and it would apply to household with incomes up to 138% of the federal poverty level. So for a household of one, the income threshold would be about $20,000 a year, household of four, about $41,000 a year. And one thing that's interesting about the expansion, I mentioned the FMAP earlier, the amount of money that we draw down to pay for medical assistance services. It's typically 60-40 federal state. There is a different allocation for Medicaid expansion. It's 90% federal and 10% state. So that's different. On the next slide, we provided a map of where we are on Medicaid expansion states. 39 states plus DC have expanded or are in their process of expanding. You can see on the map, most states around, all of our connecting states have also expanded, and almost all of them in the region. And earlier this month, it was announced that North Carolina was going to add to the expansion states. And the slide after that, I wanted to share a little bit of the financial information because I know that this has come up in budget committee hearings as well. There was a law passed in 2021, the American Rescue Plan Act, that added an additional financial incentive for states who wish to expand. It allows states to draw down 5% extra FMAP on their base Medicaid population for 8 quarters or 2 years after you start expansion. So instead of the normal 60% FMAP, we would be drawing down about 65% FMAP. And based on our estimates, there have been another number of studies done. This would bring in about $370 to $450 million over 2 years into the state. And that's really enough to cover the state's share of expansion for about 8 years. So it's a pretty good sweetener. And we do note that the governor's budget does include this in her budget. And because of those extra savings, her budget proposal would include a net savings of about $72 million if Medicaid is expanded. So I just wanted to share a little bit of information with the committee there so that you understand what we're talking about when we talk about Medicaid expansion, who that would touch, and what that would entail.
Representative Pickard.
Thank you, Mr. Chair. Do you have any idea about how many people that would be in Kansas?
Sure. Mr. Chairman, we know that some states, when they expanded Medicaid, underestimated how many folks that they thought might end up applying for expansion. So we have always maintained a conservative estimate to make sure that the fiscal note we bring to the legislature would be adequate to cover those costs. So the number that we have consistently used is 150,000. And I know that there are some estimates that believe it will be lower than that, but we feel that that is a safe estimate.
Representative Meyer. Representative Meyer.
Thank you, Mr. Chair. And thank you for bringing up the ARPA sweetener. So to clarify on this, what you're stating here is that with that ARPA sweetener, if the state of Kansas were to expand, this would essentially cost the state next to nothing for the next 8 years out of our STF in order to expand and provide health coverage to eligible adult individuals. Is that correct?
Mm-hmm. Yes.
And this may be out of your purview, but because I love to talk about it, could you explain to us a little bit how this may affect our community health centers, the mental health, community mental health centers, rural hospitals and clinics, access statewide, really in areas that have lost some of that coverage?
Sure. So, Mr. Chairman, I believe Christine will have some additional information that's relevant here. We are in the process of unwinding from pandemic-era eligibility rules. I mentioned earlier we currently cover about 540,000 Kansans. We are expecting to lose about 100,000 to 125,000 over the next year off the Medicaid rolls, and we've had providers come to us very, very concerned about the cost of uncompensated care going up, particularly community mental health centers, rural health centers, critical access hospitals, hospitals with ERs. That's something that's of grave concern to them. We do anticipate that some folks, particularly on the adult side, that we're going to be terminating over the next couple of years would be able to keep benefits if we did have expansion. So it is an area of concern that we're hearing about a lot from our providers.
Thank you. I appreciate that.
Representative Hoagland.
On the list of departments for aging and disability services, I know that the IDD has about a 10-year wait. What are the waits on the other services?
Oh boy, I don't have that information off the top of my head. We would have to get back with the committee on that. That sounds about right, yes. We do have a very lengthy wait list for that waiver.
And would Medicaid expansion help that at all, or no?
That's a good question, Mr. Chair. So it would in some regards. It wouldn't take folks off the waiver. I'll talk to the IDD waiver in particular. Right now, about 70% of the folks who are on the wait list for IDD waiver services already receive base Medicaid coverage. They're eligible, their income is low enough that they're already able to go to the doctor, go to the dentist, Medicaid will pick up the tab. 30% of them make too much for base Medicaid coverage. We do think that Medicaid expansion will allow some of those folks to come on to Medicaid so that they can go see the doctor, they can go see the dentist, and have their health care taken care of, instead of waiting for a slot to open up for that. So we do think that that would help for folks with disabilities. There's a lot of folks with disabilities in Kansas who don't qualify for any of those KDAD's administered programs, and they're kind of left in the lurch. There's no program currently in Medicaid for them. So it kind of underrepresents the number of folks with disabilities who need health care, and there's no program for them in Kansas now. So Medicaid expansion wouldn't directly take folks off of that wait list, but it would allow folks on the wait list, more folks on the wait list, to actually get base medical care.
Representative Howell.
Thank you, Chair. Just backing up a little bit to the Medicaid overview, we have one list that says what is covered by Medicaid and another one that says optional services the state covers. So does it, make sure I understand this, so the one that says optional services the state covers, does our state provide all these services?
Yes, Mr. Chairman, I do. All of these services that are listed here, they're on our Medicaid state plan, and so they're part of base Medicaid coverage.
And then also, I just wanted to double check. So hospice care is not covered under the mandatory services?
That's correct, Mr. Chairman. It's not. There's some odd facets of the federal law.
Representative Pickard.
Thank you, Mr. Chair. So you mentioned for the IDD slots had to open up. So do we just have X number of slots in Kansas? And so somebody either has to age out, turn 65 or older, or die to open a slot. Would that be correct?
So that's a really good question, Mr. Chair. And so the way those waivers work, they're not entitlement programs. They have funding limitations attached to them. So there is an appropriation that's made to KDADs, and they figure out how many folks that they can cover with that amount of money. The IDD waiver doesn't have a whole lot of fluctuation in members. Eligibility for that, I think it starts, oh, I did write this down. Give me a moment. Bear with me. Eligibility for that starts at age 5. And so you can have folks who can come on to the IDD waiver as children and stay on it kind of forever. There's not a whole lot of fluctuation in membership. And so typically slots open up for that waiver if someone passes away, if someone moves away, or if for some reason they ask to not be on the waiver anymore. There's not a lot of turnover. Some of those other waiver programs, there is a lot more turnover. So we have a brain injury waiver, that's a rehabilitation waiver meant to help folks recover if they have a traumatic brain injury or an acquired brain injury like a stroke. And once they've achieved their rehabilitation goals, they're off the waiver. So we see more turnover in those. But physical disability waiver and IDD, that's where we have the longest wait list, because a lot of the folks on those waivers, their condition is not going away. Their medical needs are not going away, and they will continue to qualify for those programs, possibly for the rest of their life.
Representative Roth.
On Medicaid, do all doctors accept Medicaid patients?
So, Mr. Chairman, no. There's no requirement that any particular doctor accept Medicaid patients. However, we find that most of them do because there are so many folks with Medicaid in Kansas.
And then and the same question with medical centers or medical service centers or hospitals. Do they all take Medicaid patients?
So, Mr. Chairman, my understanding, we require our Medicaid managed care organizations to contract with all community mental health centers, federally qualified health centers, rural health clinics. There's a list of providers that we require them to contract with, so they're always going to be in the network. I believe most, if not all, hospitals do accept Medicaid. There might be some private hospitals, smaller hospitals that maybe don't, but any hospital with an ER takes Medicaid.
Thank you very much. Thank you, Chairman.
Representative Howell?
Thank you, Chair. Just one more. Thank you. Can you remind me, I seem to recall that anybody waiting on the list for IDD, on the IDD waiver list, they're not necessarily served in order of seniority. They are prioritized according to how critical their condition is or their needs are. Am I remembering that correctly?
So, Mr. Chairman, generally there is kind of a seniority, so whoever's been on long enough, the longest, they're offered the next slot. KDADS does operate a crisis exception process, whereby if somebody, really needs access to those services because they are in crisis, they can jump the line a little bit. So it's a generally yes, the longer you've been on the waiver, the closer you are to getting a slot. However, there is that process to bypass the seniority for folks who are in crisis.
Representative Humphreys?
Thank you, Mr. Chair. So you mentioned that each state has a different FMAP. Who decides the FMAP? And what are other states doing?
Sure. So, Mr. Chairman, the FMAP is based, it's statutory, and it has something to do with the unemployment rate in the state. So states with really high unemployment rates are going to have a higher FMAP. States with a lower unemployment rate are going to have a lower FMAP. I think Kansas is somewhere in the middle, I think.
When you say statutory, federal statutes or state statutes?
That's in federal statute. Mm-hmm.
So we don't have any control over the FMAP.
That's right, Mr. Chairman. CMS advises the state on what our FMAP is going to be for each federal fiscal year. They do that math. Mm-hmm.
Representative Lewis?
Thank you, Mr. Chair. Thank you. Who determines the rate that the providers are paid?
So, Mr. Chairman, that's a good question as well. So the Kansas Medicaid program sets what we call the fee-for-service rate. So if we were to pay a physician directly, this is the rate we would pay for that particular service. And so for all the codes that we cover, we have the base Medicaid rate. For our managed care program, CanCare, we do allow our MCOs to go above that. Some of them have incentive-based contracts with providers whereby if you see a patient, if you prevent readmission within a certain time period, or if you hit other quality metrics, they'll get a bonus payment or a higher rate of pay. So we do allow MCOs to deviate from the base Medicaid payment as long as they don't go below the base amount that we would pay our providers.
Are you going to talk about the difference between CanCare? You mentioned CanCare and a managed care system. You're going to talk about that?
Yes, and Mr. Chairman, that was where we ended up on my. I'm happy to move over to it, Mr. Chairman, if you like. Okay, so I am on slide 23 in my deck. It's just a title slide that says, "What is CanCare?" That's what we had next. So CanCare is the name of the Medicaid managed care program in Kansas. And this was, CanCare came about under former Governor Sam Brownback. And what was new about CanCare is that for the first time, with few exceptions, everyone on Medicaid has to enroll in mandatory managed care. So before CanCare, I think we had maybe 40% or so of Medicaid members enrolled in managed care. After CanCare, it's about 95%. Virtually everyone is in managed care. And the remaining 5%, there's some very small programs. Most of them are 100% state funded. But for the most part, when you're talking Medicaid in Kansas, you're also talking CanCare because virtually everyone is in managed care. And on page 25, a little bit of an overview on what we do with our managed care organizations, or MCOs. We contract with 3 of them: United Healthcare, Sunflower Health Plan, which is a Centene subsidiary, and Aetna Better Health of Kansas. And the 3 MCOs collectively cover 95% of Medicaid members. They enroll providers into their system. They negotiate contracts for payment for those providers. They pay claims on behalf of their members. And in exchange for a monthly payment per member per month that we pay our MCOs, they are at financial risk for all of the healthcare costs associated with those members. So if we move on to slide 26, go into a little bit more detail on how that financing works. We pay a capitated or per member per month payment to each MCO for each member. All of our Medicaid managed care members are divided into various rate cells to kind of account for what we expect the cost of their care to be. So for instance, someone who's 75 years old and residing in a nursing facility is going to cost more per member per month than a healthy 5-year-old. So the 42 rate cells that we have distinguish between those different costs. And in exchange for that PMPM payment, the MCOs assume risk for the cost of care. So if the monthly payment for a member is $200, but they end up in the ICU, the MCO is on the hook for those costs, even though we've only paid them $200 for that month. So it's a risk-based contract. And the federal government matches all those payments. Like I said, our FMEP is about 60%, so 60 cents for every dollar. And then the providers that we have bill the MCOs for the services, and they're generally paid on a fee-for-service basis, meaning you bill us for these 3 codes, we'll pay you this rate for each of those codes. So very high level, that's what CanCare is. And Mr. Chairman, that concludes my slides. I'm happy to stand for any other questions the committee might have.
Representative Pickard.
Thank you, Mr. Chair. Would you state the managed care organizations? So Sunflower's one, and what were the other ones?
Sure.
Thank you.
Mr. Chairman, they're United Healthcare, the Sunflower Health Plan, and Sunflower is a Centene subsidiary. And then the third one is Aetna Better Health of Kansas.
Representative Meyer.
Thank you, Mr. Chair. On that note, could you kind of go over a little bit of the process of contracting with the MCOs and what that looks like?
Sure. So, Mr. Chairman, we're actually kind of in the process of rebooting all of that. So we do competitive procurements in Kansas. So in order to contract with 3 MCOs, we do a public competitive procurement. So the state puts together a request for proposals. It's posted. Anyone who wishes to bid on it can bid on it. And then the bids come in. The state evaluates them based on objective criteria. We pick the top vendors that we think can do the job the best, and then we offer contracts to them. So it's a lengthy process. The whole thing is like, we're hoping to get our request for proposals on the street in late September of this year. In all likelihood, it would be spring until those contracts are finalized. It takes several months. They're very complicated contracts.
Thank you. And can you tell me, is there a limit to how many MCOs the state accepts?
That's a good question, too. There's no statutory limit. However, we have found that 3 is kind of the magic number for a couple of reasons. Number one, federal law requires Medicaid members to have a choice in their MCOs, so you always have to have more than 1. However, if we went with 2 MCOs and we decided to terminate the contract for one of them because they weren't living up to our expectations, we would be left with 1, and then we're in trouble with the feds because there's no choice. So 3 MCOs, and also we have looked into whether 4 MCOs would make sense. Unfortunately, the business in Kansas is not really big enough and viable enough to accommodate a 4th MCO. So 2 is too few, it's Goldilocks. 2 is too few, 4 is too many, so 3 is the sweet spot.
Thank you for answering my questions.
Mr. Chairman, I think.
Thanks, Representative Hoagland.
So do all states use MCOs? You were talking about being a federal requirement.
So that's a good question, Mr. Chairman. It is not a federal requirement that you use managed care. If states opt to use managed care for Medicaid, there's a whole slew of additional rules that apply to make sure that that's done fairly. So there are some states that don't have managed care at all. They find it pretty difficult to control costs and predict how much it's going to be, because the example I used earlier, if you pay $200 a month, capitation to an MCO, that member ends up in the ICU. The MCO is on the hook for that payment, not the state. And a fee-for-service structure, the state would be on the hook for that entire cost. So it's easier for the state to predict what our costs are going to be in a managed care system, and there's also less, per claim, per member risk under managed care. So most states are moving in that direction, but there still are some Medicaid programs that do not operate with managed care.
Any further questions, committee? Looks like not. So, Sarah, thank you very much for coming.
Thank you so much, Mr. Chairman.
You're welcome. So, committee, there was another agenda item. This is more on the omnibus bill impact to unwinding. Due to time, we'll just pass on that. I think, obviously, if you have any questions, feel free to contact Kansas Department of Health and Environment, but no need to go into that right now. As far as next week goes, Tuesday, we do not have a meeting. Our meeting time, I give it to Representative Concanon for her committee. And then Thursday, we are going to have a meeting. It's going to be the big roundtable discussion on the homelessness topic. I think I can get the old Supreme Court room on the 3rd floor reserved for that meeting. We'll probably have several people there to be part of the roundtable discussion. So that would be next Thursday at 1:30. Representative Lewis?
That round table, so it's going to be members of our committee, and if you know who else or not.
So we're trying to get a lot of people who have experience in working with the homeless population, and who are not I'll just say their life experience is more boots in the ground, working with the homeless in various forms, and try to bring people from different I want to say business backgrounds, everything from members of the business community, law enforcement, city government, mental health, child care, human trafficking. We're looking at probably about 7 different areas. And certainly those people that have spent probably as long as I've been alive working with these topics. So it's going very well. The interest is much greater than I could ever have anticipated. We might actually have to turn people down. So, but it looks like a pretty wide range of people. And the goal of the meeting is just to get an understanding. Obviously, we're at the end of this session this year, but to help us get a little bit more real understanding of what goes on to cause homelessness, what happens in that time when somebody's homeless, and then what are realistic options to help reduce the number of homeless and bring them to some form of self-sustainability. And try to work with those professionals who have done that and have to work with that every day on those 3 time frames of homelessness. I think it's going to be a great meeting, so I'm looking forward to it. Representative Carr.
So do we have a list of those conferees, or?
Not yet, because I'm still working on them. Yeah, we're trying to put them together, and it'll probably actually go all the way through next Tuesday, or even pulling them all together. So, Representative Hogan.
Are we going to try and get all of the information from all of those people in an hour and a half, or are we going to have more than one roundtable?
So next Thursday is our last meeting. So this is more of an initial meeting to discuss the topic and maybe set some framework for where we can go next year if we want to continue the conversation. So no, we won't get all the information from everybody. But I think just the reality perspective of them being boots on the ground, I think it's important to listen to what they have found to be effective and work well, as opposed to sometimes more of a political angle to the topic. Yeah. With that, committee, we'll see you all next Thursday. Meeting's adjourned. Thank you.